Hello, welcome to this lecture on ultrasound of the emergency critical care patient. This lecture is going to focus on an introduction to the application of ultrasound in emergency clinical situations with an emphasis on AFAST, TFAST and vet blue examinations. Now, don't worry if these do not sound familiar, all will become apparent. There are a variety of less comprehensive scanning techniques that are validated for use in veterinary medicine. We have the flash approach, fast scanning, so your AFAST and TFAST scans, poker scanning and a global fast scan. And these scans become more complex and detailed, answering more and more questions as we ascend this pyramid. So let's take a brief look at each of these. We're going to start with the flash approach, or the flash scan, or flash mentality, as it's often referred to. And this is the most limited examination, a true sort of pop a probe on examination that often employs a whole cavity approach. The aim is to very simply answer a single binary question. Is there or is there not free fluid in this patient's abdomen, for example? So easy. Now, becoming a little more complex are the AFAST and TFAST examinations. AFAST stands for Abdominal Focused Assessment with Sonography for Trauma Tracking and Triage, and TFAST stands for Thoracic Focused Assessment with Sonography for Trauma Tracking and Triage. Now, as we're going to see shortly, there have been numerous amendments to the fast scanning protocols over the years. At one stage, AFAST and TFAST were renamed AFAST 3 and TFAST 3, the 3 standing for the trauma, tracking and triage. However, this only lasted for 6 years when the 3 was then dropped, with the resounding assumption that everyone knew that the 3 stood for the 3 T's, the trauma, tracking and the triage. Now, although the name change rocked the boats a little bit, there have been numerous other changes to both AFAST and TFAST examinations since these fast scans were first adapted for veterinary medicine in 2004. Most notably, in 2020, there were a series of updates to the AFAST protocols, renaming views and adding windows, and also for the TFAST protocols, and there have been numerous changes to both protocols, as you can see over the years. So I share this extensive roadmap of change with you to highlight the fact that every clinician has learned about emergency scanning at some point in time, and as the changes have been so frequent, textbooks and course content may no longer be up to date. And the information in this lecture regarding fast scanning is, to my knowledge, up to date as of October 2025. Now let's move on with our lives. The primary aim of a fast examination is to identify and quantify, where appropriate, abdominal, thoracic and pericardial effusion and pneumothorax. And these fast studies are intended to be limited ultrasound examinations directed at assessing urgent patient stabilisation needs, providing a systematic approach to performing serial monitoring of emergency critical care patients. Third in complexity come the POCUS ultrasonographic examinations. These are the point of care ultrasound scans. POCUS scans have a broader scope than FAST scans and are implemented to assess a specific organ or organ system. Again, specific binary questions are asked to answer questions that the clinical examination alone perhaps cannot confirm, and this results in improved decision making. In this case, for example, an intact female dog presents to your clinic with a lethargy, inappetence and vomiting. Does she or does she not have a pyometra? And in this case, we can say with a quick POCUS scan of the uterus, she does indeed have a pyometra. So that is the application of a point of care ultrasound examination. Now, when it comes to POCUS scans versus a comprehensive abdominal ultrasonographic examination, POCUS examinations can be completed in a few minutes with minimal patient preparation, and very importantly, they focus on answering specific goal-directed questions in real time, and they require minimal training. Conversely, a comprehensive abdominal ultrasound examination is a thorough, systematic scan that can take often up to an hour, including your patient preparations. So oftentimes they need sedation, you're going to be clipping the patient's hair and working with optimal patient positioning. And it does require years of training. Finally, there are the global FAST examinations. And this global FAST scan, this examination includes both an AFAST and TFAST examination, but additionally an ultrasonographic examination of the lung parenchyma with a vet blue approach, which will be discussed later in this lecture. And FastVet, who are the leading authority on the application of ultrasound in emergency critical care patients, state that FAST scans can be considered a first-line extension of the physical examination in most, if not all, patients. So FastVet state that the application of this format of brief ultrasonographic examination in general practice is boundless. And they have suggested that this type of examination could be employed in older patient wellness checks or as a pre-anaesthetic screening tool, and not only in emergency critical care scenarios. As AFAST, TFAST and vet blue examinations are combined, data for a global FAST examination is obtained from 15 imaging points within the patient. So this examination should, with practice, take actually less than 6 minutes to complete. There was a whistle-stop tour of these brief formats of ultrasonographic examinations and their increasing complexity. But this lecture is going to focus on FAST examinations. MacDonald et al. In 2023 looked at the confidence of primary care practitioners in performing point-of-care ultrasounds, such as those that might be used in an emergency situation, perhaps following an initial AFAST study, for example. Interestingly, they reported that over 30% of clinicians use a non-standardised protocol, 50% were self-taught, and only 17.4% had attended a practical course in utilising ultrasound in such settings. Furthermore, they relayed a lack of self-professed confidence in assessing the heart or thorax, and this was additionally, but not unexpectedly, supported by other studies. And I want to ask you, why could the use of a non-standardised protocol be problematic? Pause the video now and restart when you're ready. So as you well know, 360-degree rotations of the probe, breakdancing your way across the abdomen, will inevitably cause you to become lost. It's imperative that the probe is orientated correctly with the notch towards the head of the patient, and then, for the orthogonal image, rotated 90 degrees clockwise towards the patient's vertebral column. The probe can be rocked and fanned in each of the windows that will be scanned in a FAST examination. And then the scan will commence in a systematic manner, moving the probe to predetermined imaging points in a particular order. So a systematic approach that is consistently adhered to and completed in each patient avoids missed or misled diagnoses, satisfaction of search error, and confirmational bias. So the clinician may stop, for example, at the first abnormality noted, missing additional issues and searching for further evidence maybe to confirm the suspected issue rather than appreciating the entire picture. It's imperative to complete the systematic approach. Remember though, AFAST and TFAST examinations are not intended to be a comprehensive examination and cannot replace a detailed ultrasonographic study. And a detailed abdominal ultrasound can come later if needed once the patient is stable. A study in 2016 determined that 20 scans at a minimum are required by a veterinary clinician before they're performing FAST scans proficiently in a repeatable manner. And if you adhere to a consistent protocol, this is going to help you to maximise that diagnostic yield, and ultimately an AFAST examination or a TFAST examination should take the clinician less than 3 minutes. Now, ultrasound as an imaging technique has multiple limitations, as we know, and emergency situations are innately less than ideal to scan in. There's often bright ambient lighting, maybe you're having to scan in the prep room with loud noises, perhaps you're having to lean over an anaesthetic machine or distort your way into an O2 chamber, and of course you may have some highly unamenable patients to work alongside. So, how does ultrasound perform compared to other imaging techniques for determining a fusion in our veterinary patients? Now, a paper by Lisiandro et al. In 2009, this is the FastVet people, This paper indicated that utilising radiographs to assess serosal detail and thus determining if there is abdominal effusion or not is just simply not adequate. 25% of patients in their study demonstrated normal serosal detail on radiographs, but had a large volume of abdominal effusion confirmed with ultrasound. And conversely, 34% of patients in this study were deemed to have an abnormal serosal detail or poor serosal detail on X-ray, but were negative for abdominal effusion when an ultrasonographic study was performed. I thought this was very interesting. So let's look at ultrasound versus CT. For the detection of effusion in the abdomen, there is moderate to excellent agreement between ultrasound and CT. In the thorax, there is slightly less agreement, with ultrasound actually conferring a greater sensitivity for the detection of pleural effusion than CT. There was, however, a poor agreement for the detection of free thoracic gas. CT outperformed ultrasound in the detection of pneumothorax. In summary, fast examinations can reliably determine the presence of free fluid in both the thorax and the abdomen. So let's move on to AFAST, abdominal focused assessment with sonography for trauma tracking and triage, more specifically. When is it necessary to employ an AFAST examination? It could be used as a continuation of the clinical examination to confirm maybe uncertain clinical suspicions. Using it as a first-line non-invasive screening tool is brilliant, and it might help you guide initial stabilisation of a patient and possibly help you to decide the subsequent therapeutic plans. Helpfully, it can provide a baseline from which the patient can be serially monitored with ultrasound. So common indications for an AFAST may include a patient that's undergone trauma, a collapsed patient, a patient with acute abdomen, or a patient with anemia. Regarding patient preparation, the point of fast scanning is that it is performed as expediently as possible. Clip patches are a luxury in these patients, and anyone who knows me knows that I say this begrudgingly. However, in certain cases, clipping the hair is just not possible. So, part the fur, spray surgical spirit or water, and apply gel if you can, and surgical spirit will often suffice. Now, the ever so controversial topic of patient positioning. It's important to note that the position of the patient has no effect on the detection of abdominal free fluid. Any position will suffice for the detection of free fluid. Now, it was initially recommended to perform an AFAST examination in left lateral recumbency. This has changed, and any position was then accepted. Now, however, currently, we employ right lateral recumbency. It's preferred, and for good reason, actually. It's the position most clinicians are familiar with when scanning. Abdominocentesis is considered easier. Certain organ evaluations are less cumbersome in this recumbency, and there's better visualization of the rectoperitoneal space. And of course, helpfully, it's the position we put the patients in for ECG lead placement. So let's talk more specifically about effusion now. The ultimate aim of an AFAST is to look for fluid in certain regions of the abdominal and retroperitoneal cavities. Anything else is a bonus and constitutes a more comprehensive scanning technique. This is the take-home message of the night. So effusions are typically found adjacent to organs. This is where the fluid likes to hide out. Effusion can appear anechoic or black or echogenic. Echogenic fluid or fluid with hyperechoic speckles can be the result of protein, fat, or cellular content. And it's important to remember that ultrasound alone cannot definitively determine the type of fluid, but it is rather good at it. But paracentesis is required to determine the etiology of an effusion. The abdominal effusion in this patient is anechoic. Fluid analysis revealed a transudate, which aided in the diagnosis of PLE in this particular patient. Here we have uterine horns filled with anechoic fluid. Can we, with ultrasound, rule out a pyo? No, we can't, and this patient had a very, very nasty pyometra, but the fluid in this case was indeed anechoic. We're going to sample the fluid with ultrasound guidance, and I find a 23 gauge needle often more than adequate, but thicker fluids may require a larger needle. This fluid can of course be urine, blood, bile, transudate, modified transudate, or exudate. And irrespective of the type of fluid, typically a specific gravity, total protein and cytology are performed, with a PCV of this fluid appears bloody or blood-tinged. Some other measurements which might be useful include measuring the fluid creatinine, which is typically 2 to 4 times higher than the serum in case of uroabdomen. Potassium is usually higher too in these cases. Total bilirubin can be elevated compared to the serum in rupture of the biliary tree, and Pap green crystals might be observed too. Amylase in the fluid can be measured on the biochemistry machine and is elevated in case of pancreatitis or bowel ischemia, for example. Okay, how long should an AFAST examination take on average? 30 seconds, less than 3 minutes, 10 minutes, or 15 minutes? Less than 3 minutes. Well done. Now, how many windows of the abdomen are scanned in an AFAST examination? Pause the video now, restart when you're ready. Over the past few years, the traditional AFAST examination has changed somewhat. There are now 5 acoustic windows that are routinely scanned systematically for a complete AFAST assessment. And these views are named for the anatomy in the region to be imaged, aiding in reinforcing the standardised approach to imaging the abdomen. There was, of course, until recently only 4 windows. So the 5 windows now, in order of scanning, are the diaphragmatic hepatic window, DH window, the splenorenal, SR window, this is the spleen and the left kidney, the cystocolic or CC window, the splenointestinal umbilical, SIU window, and hepatorenal, HR window, which is the liver and the right kidney. And it's recommended that you systematically practice this approach. If variations in an appearance of an organ is noted, FAST vet recommend recording them as suspect lesions, as the AFAST is not assumed to be diagnostic and does not replace that detailed abdominal ultrasound, which, if there are suspect lesions, may be warranted once the patient is stable. With correct probe orientation, the left side of your ultrasound screen will represent the cranial aspect of the patient when the notch of the probe is positioned in a cranial direction. So once more, we're going to start at the diaphragmatic hepatic window, moving to the splenorenal window second, then the cystocolic window, and the splenointestinal umbilical window, before moving our probe almost under the patient when lying in right lateral recumbency to assess the hepatorenal window. Let's start at the start. The diaphragmatic hepatic window is the first AFAST window. Assessment of the diaphragmatic hepatic window requires a subxiphoid approach where the ultrasound probe is placed just caudally to the xiphoid process, angled towards the patient's neck. The field of view, or FOV, should be set at a depth to allow comfortable assessment of the hepatic parenchyma and the hyperechoic diaphragmatic line, which can be seen in this image here. To obtain this image, lower the frequency of the probe and increase the depth or field of view. And remember the rule with ultrasound, there is an inverse relationship between frequency and wavelength. And this means that the lower the frequency, the greater the attainable scanning depth. And the liver and the diaphragm in a normal patient should be in contact. Do remember the mirror image artifact? If this artifact is observed, it excludes the presence of pleural effusion, as the mirror image artifact can only occur when there is gas, typically within the pulmonary parenchyma, adjacent to the diaphragm. With this approach, it's also possible to visualise the gallbladder and obtain a transdiaphragmatic approach of the pericardium beyond. The gallbladder is located between the right medial and quadrate lobes of the liver, and effusion or hyperechoic fat, steatitis, adjacent to the gallbladder may indicate biliary leakage, rupture, or bile peritonitis. Does it fit the clinical picture? It's important to note that when observing the thoracic cavity with the diaphragmatic hepatic window, looking beyond the hyperechoic diaphragmatic line, effusion may be noted on the thoracic side of the diaphragm. However, with this view alone, it may not be possible to adequately differentiate or determine whether effusion is pleural or pericardial in origin. So if free fluid is seen on the thoracic side of the diaphragm, it's absolutely necessary to perform a TFAST examination. Angling the transducer towards the patient's head or neck will ensure that the obtuse margin of the liver is imaged in its entirety and the image is not obscured by gastric gas. It's often rather challenging, if even possible, to delineate one liver lobe from another. However, when abdominal effusion is present in this window, the diaphragmatic hepatic window, it can be visualized as a fluid strip between the liver and diaphragm, but also as pockets of fluid between the liver lobes themselves. The second window scanned during an AFAST examination is the splenorenal window. This window will assess for effusion between the spleen and the left kidney. A higher frequency should be employed with a decreased field of view as the spleen and left kidney are positioned, usually, very superficially on the dorsal aspect of the left abdomen, just caudal to the last rib. And due to the more mobile nature of these organs, particularly in feline patients, it can be that little bit more challenging to obtain a view of them simultaneously, adjacently in the same field of view. In cases where this is not possible, the ultrasound probe can be fanned between these two organs, the spleen, the left kidney, the spleen, the left kidney, to assess for abdominal effusion. Furthermore, small pockets of fluid adjacent to the kidney in this region may deliver a challenge in determining if the effusion is peritoneal or retroperitoneal in origin. The cystocolic window is the third of the AFAST acoustic windows. This view is assessing for abdominal effusion in the caudal abdomen between the urinary bladder and the descending portion of the colon. A lower frequency is required, most likely, and can vary depending on the degree of bladder distension, and adjust the field of view accordingly. This window is approached ventral to the left flank of the patient, ideally, or maybe with a more ventral midline approach. Just remember, in an intact female, such as in this image, the uterus lies between the urinary bladder and the descending colon. It's often necessary to fan the ultrasound probe up dorsally through the left flank of the patient to locate the descending colon, if both organs are not visualized in the same field of view, that is. Gentle fanning between the bladder and the descending colon, will allow for assessment of effusion in this window. And ensure that not too much pressure is applied with the ultrasound probe, as this may cause collapse of an almost empty urinary bladder, which can actually cause a little bit of confusion. On to the fourth window, the newest addition to the AFAST club is the SIU window, the splenointestinal umbilical window. This view gives a good overview of the mid-abdominal cavity, the bulk of the splenic parenchyma and the intestines, and their associated mesenteries primarily. So place the transducer on the umbilicus, angled towards the vertebral column, and adjust the field of view as necessary to obtain an image similar to this one, the spleen in the near field and the jejunal loops in the far field. And this is the site in which abdominocentesis is usually performed, as it is the most gravity-dependent site. Remember, the mesenteries can appear overly hyperechoic due to the presence of anechoic effusion in the abdominal cavity and the effect of the distal acoustic enhancement artifact. The hepatorenal window, this is the last of the 5 AFAST windows. So the right kidney sits in the renal fossa of the caudate process of the caudate lobe of the liver. This acoustic window can be located rather cranially, and as the patient is typically lying in right lateral recumbency, an approach from underneath the patient is usually required. When effusion is present, as you can appreciate in this image, it can really add contrast between the right kidney and the hepatic parenchyma. As without the effusion, it can actually be more challenging to delineate the right kidney and the liver due to their anatomical proximity. So ultrasound, as we know, is the most user-dependent imaging modality. And it's important to note that while we are looking for free fluid and quantifying it where necessary, we can assess the parenchymal organs as we scan. However, where ultrasound for fluid detection is highly sensitive and specific, the same cannot be said for organ evaluation. However, more recently again, fast examinations have evolved from purely an assessment for the presence of effusion to something a little more comprehensive, with the invention of add-ons. So these add-ons allow the sonographer to quickly assess the urinary bladder for uroliths, for example, while scanning the cystocolic window, or the gallbladder for a biliary mucocele while assessing the diaphragmatic hepatic window. This more comprehensive approach to the classical AFAST examination considers these further, albeit brief, assessments to be add-ons to the basic fast scanning foundation, a skill that can be developed as the clinician gains experience with ultrasound. I personally feel that a fast examination is just that, a quick assessment for the presence and quantification where necessary of effusion. It doesn't need to be anything more than it is. POCUS examinations exist to bridge the gap between a brief format of ultrasonographic examination and a comprehensive, more costly and ultimately more diagnostic abdominal ultrasound. So, let's talk more specifically about hemoabdomens. In a patient with a hemoabdomen, it's important to obtain a good history and take into consideration the signalment and perform a clinical examination. Is this hemoabdomen due to trauma, a coagulopathy, or is it a spontaneous hemoabdomen due to a neoplastic rupture or anaphylaxis? In one study, 80% of patients presenting with a hemoabdomen presented due to bleeding of a malignant neoplasm, 70% of which were hemangiosarcomas. Splenic, hepatic, and adrenal neoplasms are the most common offenders here. Hemoperitoneum is diagnosed by obtaining a sample of non-clotting blood that has a PCV that is comparable, usually, to the circulating volume, or we can say that a sample of non-clotting blood with a PCV greater than 10% is consistent with a hemoabdomen. As we've already learnt, a fast examination provides a rapid and accurate diagnosis of an effusion in veterinary patients. Sampling then obtains a diagnosis of hemoabdomen. We have qualified the presence of a hemoabdomen. With abdominal fluid scoring, we're not only stating that fluid is present or absent, which is the classical AFAS, but we are quantifying the volume of hemorrhage, which should guide imminent clinical decisions and treatment options. It's important to note that a system of abdominal fluid scoring, or AFS, as described by Lisiandro et al. In 2009, was designed for implementation in post-trauma patients with hemoabdomen. It's currently only validated for use in patients with hemoabdomen and not for patients with any other forms of effusion. Okay, how do we perform an abdominal fluid score? This fluid scoring system is implemented once the patient is in right lateral recumbency, and any repeated assessments must employ the same position. So if a patient is positive for abdominal fluid when assessed standing or in any other position, lie them down in right lateral recumbency and wait 3 minutes before fluid scoring to allow accurate results. Now, there is a more recent study in 2023 that suggests a good agreement between an abdominal fluid score obtained in standing and one in lateral recumbency for quantifying peritoneal effusion. Now, of the 5 views obtained for an AFAST examination, only the first 4 are used for abdominal fluid scoring. The 4th window, the splenointestinal umbilical window, has replaced the hepatorenal window for an abdominal fluid score. So we do not score the 5th window. You can score the fluid as being present or absent in each of the initial 4 AFAST windows and further highlight the volume of fluid present. This is useful for monitoring bleeding patients or assessing the response to therapies. More on that in a moment. So how does an abdominal fluid score work? A score needs to be attributed to each of the diaphragmatic hepatic, splenorenal, cystocolic, and splenointestinal umbilical AFAST windows. So score the window 0 if there is no fluid present, half if there is a small volume of fluid present, and 1 if there is a larger volume of fluid present. Now, a small volume means less than 1 centimetre in a dog and less than 0.5 centimetres in a cat. This is termed a weak or a soft positive. A large volume, termed a strong or a hard positive, is a measurement of hemorrhage greater than 1 centimetre in a dog and greater than 0.5 centimetres in a cat. Okay. The depth of the fluid should be able to be measured on your machine with a caliper or measurement button as a simple distant measurement, point A to point B. Measure the widest part of the fluid pocket or the fluid strip. Okay, this is a canine patient here with hemoabdomen. Is this volume of effusion considered a weak or strong positive in a dog? It is indeed a weak positive. By the way, I am aware that this window, the hepatorenal window, is not typically implemented in an abdominal fluid score. It's just a pretty picture to demonstrate the measurements. Here, in this second example, we have a feline patient. This is the diaphragmatic hepatic window. Is this volume of effusion considered a weak positive or a strong positive in a cat? It is indeed a strong positive. Well done. Okay, the fluid scores can then be tallied to calculate the current total abdominal fluid score. If the total score is less than 3, so a score of 1 or 2, then this is considered a low volume hemoabdomen. If the score is either 3 or 4, the total score that is, then this is termed a high volume hemoabdomen. These scores, both the individual window scores and the tallied score, can then be compared in subsequent scans, which can track the deterioration or improvement of the patient with regards to a hemoabdomen. Okay, step by step. Firstly, you're going to perform an AFAST examination. Sample the fluid if it's present. If the patient has a hemoabdomen, you're going to perform an abdominal fluid score. And you're going to check each of the 4 initial AFAST windows. If the fluid is present in those windows, you're going to measure the widest part. You're going to grade the volume of free fluid in each of the windows as a strong or a weak positive. Tally a total score from each of the 4 AFAST windows, and then you're going to grade the hemoabdomen as a low volume or high volume hemorrhage. Let's take a look at a couple of examples. We have here a lovely little Vizsla that was hit by a car. Poor dog. The diaphragmatic hepatic window, there's 3 centimetres. Is this given a score of half or a score of 1? That's right, it's given a score of 1. The splenorenal window, 0.7 centimetres. We give that a score of half. Very good. The cystocolic window has nothing. We give it a score of 0. The splenointestinal umbilical window, 0.8 centimetres. Is this a score of half or a score of 1? It's a score of half. Okay, this gives us a total score of 2, and this is a low volume hemorrhage. Our second example is also a Vizsla who was also hit by a car. In the diaphragmatic hepatic window, we have 1 centimetre of effusion, a score of 1. Splenorenal window, we have 2.5 centimetres. Is this given a score of half or a score of 1? Score of 1. Cystocolic window, 2 centimetres, also given a score of 1. I think you have the hang of this now. The splenointestinal umbilical window, 1.7 centimetres, also given a score of 1. We can tally these windows together. That gives us a score of 4. So this is a high volume hemorrhage. So why is the abdominal fluid scoring system helpful in an emergency setting? An abdominal fluid scoring system allows the clinician to gauge and grade the severity of the injury, guiding imminent therapy and interventions. A study by Lysander et al., again in 2009, demonstrated that in 101 dogs with hemoabdomen obtained from a road traffic accident, patients with a higher abdominal fluid score had more severe anemia, increased need for blood transfusions, increased ALT, and increased blood lactate. In summary, they stated that the higher the abdominal fluid score, the more severe the injury, which necessitates more aggressive therapy and interventions. Now, very interestingly, the same study showed that if the patient scores less than 3 on their abdominal fluid score and is anemic, you need to rule out a pre-existing anemia, bleeding elsewhere, so perhaps doing a TFAST examination, hemodilution, or lab error. So one of the merits of the abdominal fluid scoring system is that the patient can be serially monitored for resolution or progression of the hemoabdomen. A structured, systematic approach to the AFAST examination and scoring system is required to ensure repeatability and subsequent comparability of results. Serial AFAST examinations can be performed every 2 to 4 hours or more frequently, as dictated by the clinical scenario and the clinical status of the patient. Remember, patients with a negative examination on initial presentation may go on to develop detectable abdominal effusion over the ensuing hours. Serial monitoring with fast examinations favourably impacts patient outcomes, and it may help to isolate the source of the bleed. So shall we take a little look at this further? Here we have another Vizsla, poor thing, in another road traffic accident. Initially, you can appreciate that there is an abdominal fluid score of 1.5 in this patient with a hemoabdomen. This patient is scanned 3 hours later. Now there is 2.5 centimetres of fluid at the diaphragmatic hepatic window. The fluid score in that region remains 1. In the splenorenal window, the volume has increased to 1.7 centimetres, which gives us a score in this window of 1. In the systolic window, there is now 0.8 centimetres, which gives us a score of 0.5 in this window. And in the splenointestinal umbilical window, a volume of 2.1 centimetres, which gives us now a score of 1. So you can see that within 3 hours, this patient has shown a marked increase in the total abdominal fluid score, which is now considered a high volume hemoabdomen. This patient is continuing to bleed. If we look back at our initial AFAST examination and abdominal fluid score, we can see that most of the hemorrhage was located at the diaphragmatic hepatic window. With repeated examinations, we could confer that the bleeding might be coming from the liver parenchyma or its associated vasculature. So in trauma patients, an increasing abdominal fluid score indicates ongoing intra-abdominal bleeding, while a decreasing abdominal fluid score, of course, will suggest a resolution of the hemorrhage. And we expect a hemoabdomen to be resolved in 48 hours typically if there is no ongoing blood loss. So when fluid volumes persist, especially in large volume effusions, it can be recommended to investigate further. So let's quickly check in which AFAST windows are included in the abdominal fluid score. It is indeed diaphragmatic hepatic, splenorenal, systolic, and splenointestinal umbilical windows, the first 4 windows of the AFAST examination. Now let's move on to the thoracic examination. There are 2 validated ultrasonographic techniques for assessing the thorax in veterinary patients, TFAST and VET Blue. A TFAST examination focuses on the spaces within the thorax, the pleural and pericardial spaces. Thus, a TFAST is employed to rule in or rule out a pleural effusion, a pneumothorax, or pericardial effusion. The VET Blue examination, on the other hand, is employed to assess the pulmonary parenchyma, looking for ultrasonographic evidence of interstitial alveolar disease and consolidation signs. With regards to patient positioning for thoracic ultrasonographic examinations, TFAST and VET Blue can be performed in either standing or sternal positioning or alternating left and right lateral recumbency. But sternal positioning is probably the easiest and safest, reducing risk in patients with pleural effusion and decreasing atelectasia, which can happen in minutes of lying down in lateral recumbency and may lead to questionable significance of a consolidated or collapsed lung lobe, for example. Now, before we delve any deeper into these systematic thoracic scans, a couple of important concepts must be understood. Gravity, the visceral parietal pleural interface, the glide sign, and A-lines. Let's start with gravity, our friend gravity. So fluid should fall dependently towards the table in our patients, and gas, well, it should rise to the highest possible point within our patients. So with the patient in sternal recumbency, free thoracic gas should rise to the chordodorsal aspect of the thoracic cavity, where pleural fluid should sit ventrally in most cases anyway. In any thoracic scan, we need to assess the visceral parietal pleural interface and observe the movement between the two. Lungs and mediastinum aligned with visceral pleura, ribs and the thoracic wall aligned with parietal pleura. And when the patient breathes, the visceral pleura coating the lung is going to glide against the parietal pleura of the thoracic wall. So we have to take a moment to examine the gaiter sign. The ultrasound probe is held steady on the patient between 2 ribs with a notch pointing towards the head of the patient, and images like this will be obtained. The rib heads are visible there, casting clean distal acoustic shadows into the far field. And just beneath the skin and intercostal muscles, there is a hyperechoic line visible. This is the visceral parietal pleural interface. So why is this particular image referred to as the gator sign, you might ask? Well, the rib heads appear like the eyes of an alligator peering above a waterline. You have to hold the probe very, very steady at this point to observe the glide sign. So when the ultrasound probe is placed on the chest wall in an intercostal space, that hyperechoic line is going to be visualized running just deep to the ribs and the intercostal muscles, and this line should, in a normal patient, glide to and fro, moving with the patient's breath. So what is this prominent hyperechoic line? This is the visceral parietal pleural interface, or as it's also called, the pulmonary pleural interface or the lung line. With the glide sign, it's important to observe a to and fro movement of the lung line, but also a rhythm, movement with every breath the patient takes, in and out and to and fro, which is beautifully demonstrated in this clip here. Rhythm and movement. A-lines are horizontal hyperechoic lines that run parallel to the visceral parietal pleural interface within the lungs. They occur due to the reverberation artifact and they indicate aerated pulmonary parenchyma. Right, now we understand the basics. Let's start with the VET-Blue examination. So what does the VET-Blue acronym stand for? VET, obviously. Blue is beside lung ultrasound examination or brief lung ultrasound in emergency, or any combination of those words there. And it's called blue for cyanosis, obviously. And the VET-Blue examination looks specifically at the lung tissue. But can you normally see lung parenchyma on ultrasound? What do you think? The correct answer here is, of course, a resounding no. So when normally inflated, you cannot see lung parenchyma on ultrasound. Why? The soft tissue air interface has a very, very high reflective value, approximately 99.9%. So the ultrasound waves emitted by the machine are almost fully bounced or echoed back and cannot penetrate further into the lung tissue. This highly reflective surface, the surface of the lungs, causes a ping-pong effect of the ultrasound waves between its reflective surface and the transducer many times over, and this is how the reverberation artifact, or A-lines, occur. The principle of VET-Blue is that diseased lung usually contains infiltrate of either cells or fluid, which allows the ultrasound to pass deeper beyond the pleural surface. And this examination, as with all the techniques described in this lecture, follows a structured, systematic approach. Now, there is another scoring system, to assess both the presence and distribution of B-lines, which are indicative of fluid or cells in the outer portion of the lung tissue, as well as described criteria for naming signs of consolidation within the pulmonary parenchyma, namely nodule sign, shred sign, tissue sign, and wedge sign, which is a little out of the remit of this lecture today. This systematic approach is fairly analogous to how we are taught to interpret thoracic radiographs. It's performed on both the left and right side of the patient, and there are 4 windows that should be imaged. The 4 windows are the chordodorsal window, the perihilar window, the middle window, and the cranial window. There is a 5th window which may be used, which is the diaphragmatic hepatic window, which was previously discussed as the first window of our AFAST examination. Each window is scanned with 3 intercostal spaces. So the chordodorsal window is usually the 8th to 9th intercostal space. The perihilar window, the 6th to 7th intercostal space. The middle window, the 4th to 5th intercostal space ventrally. And the cranial window, the 2nd to 3rd intercostal space. During a VET-Blue examination, the lung line is interrogated, checking the glide sign and the presence of A-lines or B-lines. As we've mentioned, A-lines are the result of normal reverberation artifact found in innately gas-filled normal lungs. The presence of A lines in conjunction with a normal glide sign indicates normal, dry lungs. B lines, also called rockets or comet tails, run perpendicular to the A lines and the visceral parietal pleural interface or lung line, and importantly the B lines obliterate the visualization of A lines in the far field. And B lines occur due to the presence of fluid or cells in the outer 1 to 3 millimetres of the lung tissue, and these rockets or comet tails shooting into the far field are indicative of interstitial alveolar disease. The question is, are B lines always significant? How many B lines are considered clinically significant? Pause the video now, restart when you are ready. When there are more than 3 B lines per field of view, this is considered indicative of pulmonary pathology, and interestingly, the severity of pathology can be correlated to the number of B lines present. And this is something one could talk about for hours, but a picture says 1,000 words and saves us a little time. So this image depicts A lines on the left, normal dry lung. And there is progressively an increasing amount of B lines through the images moving towards the right. And very importantly, this is correlated with worsening pathology. The image on the left has those beautiful A lines. The next image towards the right has 1 B line, then 2 B lines, then 3 B lines. And as you can see, we're progressively getting more and more B lines here till we have 5 B lines and then 1 confluent B line in the image on the far right, which is suggestive of very wet lungs. Now it's your turn. These are images taken from a great study assessing B lines present in dogs with varying stages of mitral valve disease. What do you see in image A? Yep, A lines. Fantastic. What do you see in image B? 2 B lines. Very good. What do you see in image C? In each intercostal space, I see 4 B lines. What about in image D? Yes, 1 giant confluent B line. Very, very wet lungs. We've stated that greater than 3 B lines per field of view, or between 2 ribs, represents interstitial alveolar disease. Differentials might include pulmonary edema, pneumonia, vasculitis, pulmonary thromboembolism, hemorrhage or lymphoma, for example. So how can we narrow down the list of differential diagnoses when significant quantities of B lines are present? Okay, the location, the distribution of the affected pulmonary parenchyma is often very important, but also the clinical presentation of the patient, the history and the signalment. What species, breed and age is the patient? What's the deworming status? Are there any other comorbidities or recent traumatic events, for example? And don't forget the stethoscope. Auscultation is also invaluable. Regarding distribution, a wet lung pattern, or B lines, located caudodorsally in a patient with recent seizure activity or electrocution, for example, could indicate non-cardiogenic pulmonary edema. Hemorrhage from lungworm, typically a caudodorsal or peripheral pattern. You might have hemorrhage or contusion at the point of impact in trauma. Aspiration pneumonia typically affects the right middle lung lobe or ventral in all lung lobes. And cardiogenic pulmonary edema is typically perihilar in dogs. Cats, of course, they have their own rules, as we know, pure evil, when it comes to fluid and diagnostics. Here I have a modification from a table found in Focused Ultrasound Techniques for the Small Animal Practitioner, published in 2014. And this may help you to narrow down the list of differentials in a patient that is tachypneic or dyspneic. And yes, ultrasound is great, of course, but radiographs can provide a more detailed and comprehensive assessment of the distribution of affected pulmonary parenchyma and the extent of pulmonary disease. It can always be recommended to follow up with radiographs when it is safe to do so in our veterinary patients. Okay, what might B lines in the perihilar pulmonary window of a dyspneic canine patient with mitral valve disease likely represent? Lungworm, pneumonia, electrocution, or left-sided congestive heart failure? What do you think? Yes, left-sided congestive heart failure is the most likely answer. Okay, so where vet blue is employed for assessment of the lungs specifically, a T-fast examination is utilised to rule in or rule out free pleural fluid or air and pericardial effusion. T-fast stands for Thoracic Focused Assessment with Sonography for Trauma, Tracking and Triage. And T-fast utilises 3 windows but 5 imaging points. The chest tube site is imaged on both the left and right of the patient, as is the second site, the pericardial site. The diaphragmatic hepatic window, yes, the same one obtained in the AFAST and vet blue examination, needs only to be imaged once. In general, the notch of the probe is pointing as usual towards the head of the patient, and we can move the probe into the adjacent intercostal spaces for assessment and fan the probe dorsally and ventrally, and of course rotate that probe 90 degrees to obtain the orthogonal images and ensure a more comprehensive examination. Remember, with the T-fast, we're looking for free pleural fluid and free pleural gas. Positioning of the patient must be taken into consideration for this examination. The chest tube site is located between the 7th and 9th intercostal spaces, dorsally on the patient. This view, as can be expected, is employed to rule a pneumothorax in or out. It's very important to keep the ultrasound probe as stationary as possible during this portion of the examination. As for detection of a pneumothorax, we need to observe no movement, no glide sign, so keep that probe as still as possible. Employ a high frequency in the probe and a field of view of roughly 2 to 6 centimetres. Now, if the patient is in lateral recumbency, the gas should rise to the highest point of the thoracic cavity, and this will be, when in lateral, the widest part of the chest. The second window is the pericardiac site, which is typically obtained between the 5th and 6th intercostal spaces, ventrally, where the apical beat is strongest. The probe notch again should point towards the head of the patient and then at 90 degrees clockwise towards the patient's vertebral column. Fan through the heart one way and then the other to observe pericardial effusion. The final window of the T-fast examination is the diaphragmatic hepatic window. Image again in a longitudinal plane with the transducer parallel to the table. Position the probe at the level of the xiphoid process angled towards the patient's neck and set the depth to approximately 10 to 15 centimetres to be able to see the cardiac structures. A T-fast examination is checking for the presence of pleural effusion, pneumothorax and pericardial effusion. So we're going to look through each of these individually. Let's start with pleural effusion. Pleural effusion could be a chylothorax, pyothorax or hemothorax. Pleural effusion can be caused by heart failure or trauma. It could be idiopathic, due to a coagulopathy or neoplasia or hernia, infection or lung lobe torsion. Smaller volumes of effusion can form in pockets and may be a little more challenging to observe. In the image on the left, for example, the pulmonary mass here provides a good acoustic window for imaging and identifying the adjacent effusion. The volume or extent of pleural effusion may be more easily determined with radiographs. Pleural effusion can cause fissure lines, retraction of the lung lobes from the ribs, scalloping of the lung lobes ventrally, which is an annoying normal variant in barrel-chested dogs, and rounding of the costophrenic margins, plus, of course, border effacement of the cardiac silhouette and diaphragm. So border effacement on a radiograph is the loss of clear demarcation of a soft tissue structure. For example, we can say in this lateral radiograph that there is border effacement cranially and caudally of the cardiac silhouette. The margination of this very important piece of anatomy cannot be observed, and this is due to the presence of pleural effusion, but can also occur due to consolidation of a lung lobe or an alveolar pulmonary pattern, for example. Time for a clinical check-in. Is pleural effusion typically bilateral or unilateral? Pleural effusion should pool on both sides of the patient. There are fenestrations in the mediastinum, window-like little holes, that should allow fluid and gas to distribute on both sides of the thoracic cavity, left and right. However, sometimes there is only unilateral pleural effusion. This can be due to the presence of a thick fluid that cannot pass through these little fenestrations, or due to concurrent pleuritis that closes the fenestrations over, or annoyingly, due to a strange anatomical situation in which the patient just doesn't have any fenestrations. And remember, focal unilateral effusion may occur with certain neoplastic processes, lung lobe torsion, or diaphragmatic hernias. Moving on to pneumothorax. Remember, if the patient is in sternal recumbency, image the left and right chest chordodorsally. Look for the ultrasonographic features of a pneumothorax. Ultrasonographic features of a pneumothorax include no glide sign, no B-lines, and observation of a lung point. A lung point is the point at which the glide sign now appears again and indicates the A-lines, which can be seen, are inside the pulmonary parenchyma again. Now, this lung point may not be visible in a very large pneumothorax. So you're going to obtain a view of the gaiter sign. Is there any to or fro movement of the hyperechoic line that is just beneath the ribs? Or are those A-lines just stationary? With a pneumothorax, we're going to see the A-lines because it's gas. However, this gas is outside of the pulmonary parenchyma. It's within the thoracic space. So as the patient breathes, there's not going to be any movement or any rhythm of those A-lines. In summary, you will see A-lines, but no movement. No glide sign as the air is within the thoracic cavity and not within the pulmonary parenchyma at this imaging point. The presence of a glide sign, and B-lines actually, will rule out a pneumothorax. Now, there are a lot of papers comparing the sensitivity of ultrasound versus X-ray for detecting pneumothorax in human medicine. And in human medicine, ultrasound is fairly unanimously reported to have a better detection rate than X-ray. Maybe the same is true in veterinary medicine. However, this is highly dependent upon user experience. Lisiandro et al. In 2008 indicated that a TFAST examination has an average sensitivity of 78% and specificity of 93% for detecting pneumothorax. They further reported that the sensitivity of a TFAST for the detection of a pneumothorax dramatically increased when the examination was performed by an experienced sonographer or radiologist, and was rather lower, approximately 45%, when performed by an inexperienced clinician. It's not as foolproof as an AFAST examination, so practice, practice, practice. And on to the final brief topic of this lecture, pericardial effusion. Of dogs presenting to referral hospitals with cardiac disease, approximately 7% have pericardial effusion. Large volumes have typically developed over time and stretched the cardiac sac, allowing accommodation of the fluid, to a degree anyway. Neoplasia is considered the most common cause of pericardial effusion. Mangiosarcomas, chemodectoma, mesotheliomas are the most likely offenders here. The literature differs a little, but approximately 2/3 of pericardial effusions are neoplastic in origin. Overall, though, over 90% of pericardial effusions are either neoplastic or idiopathic in origin. And idiopathic pericardial effusion is often linked to immune-mediated or inflammatory processes. Small volumes of pericardial effusion are not uncommon in patients with left-sided congestive heart failure. Larger volumes, as they are more problematic, do require draining. It's important to note, though, that a small volume of pericardial effusion can be just as hemodynamically disastrous as a large volume of effusion if it is acquired rapidly. So you need to watch out for cardiac tamponade. Cardiac tamponade is the collapse of the right side of the heart due to pressure from pericardial effusion. And tamponade appears typically as a diastolic collapse of the right atrium, most typically, and can be visualised on echo. If tamponade occurs acutely, the patient typically will present with marked weakness or collapse. A more chronic tamponade can lead to right-sided congestive heart failure. And on radiographs, a large globoid ball-shaped cardiac silhouette can be observed in cases of pericardial effusion. Now, when it comes to practice obtaining each of the 5 AFAST windows. 20 scans is all it will take to become proficient at this scanning technique, being able to perform this examination in an accurate and repeatable manner. For the thorax, practice both the TFAST and VetBlue techniques. Appraise the glide sign, watch the to and fro rhythm and movement. Observe A-lines and count the B-lines when you see them. And that concludes this lecture. If you have any questions, please don't hesitate to reach out. Thank you so much for your attention. Bye.